Hello, my name is Jonathan Friedman, and I am pleased to welcome you today to Tired and Wired Sleep and Hyperarousal with our very, very special guest, Anne Germain, founder and CEO of Noctum Health. For those of you who are long-standing attendees of our webinars, welcome back. And for those of you who are new to EH in Canada, we are a leading nationwide network of treatment centers for addiction, trauma, and mental health. We offer inpatient services with centers coast to coast, as well as intensive outpatient and virtual options. For more information, visit our website at ehncanada.com. Everyone is on mute and cameras are turned off for today's webinar, but we'd like you to use the Q&A box at the top of your screens to submit your questions for our speaker throughout the session. We will be sending you a follow-up email in the next week that will contain a link to the recording of today's session and, for the first time in a while, a CEU credit, so those will be included. To stay updated on our future webinars and newsletters, we invite you to opt into our mailing list by filling out the form that has been linked in the Q&A chat. I'm located in Toronto, which is on the traditional territory of several nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. It is covered by Treaty 13 with the Mississaugas of the Credit. If you are new to this work and want to find out whose land you are on or grew up on, please visit www.native-land.ca. Now to introduce our very fantastic speaker today, Dr. Germain. Dr. Germain has published over 200, that's a lot, peer-reviewed articles, invited papers, and book chapters on insomnia, nightmares, treatment of sleep disorders, and sleep in the context of PTSD and other trauma-related disorders. She co-edited a book entitled Sleep and Combat-Related PTSD and a special edition of the journal Sleep Medicine on Sleep and Performance. She has served on various committees of the Sleep Research Society and American Academy of Sleep Medicine, served as program chair on the annual sleep meeting from 2018 to 2020. She has served on various research review committees from the Department of Defense, the National Institute of Health, the Canadian Institutes of Health Research, and the Department of Veteran Affairs. Now, without further ado, my friends, I will hand it over to Anne. Welcome, Anne.
Thank you. It's a pleasure to join today, and good morning, good afternoon to everyone who is joining. I'm going to go through my slides. As Jonathan said, please do write your questions in the Q&A, and I'll make sure to address as many as I can at the end of the presentation, and if not, we can always follow up online. So today I'm going to speak about sleep. I always talk about sleep. If you've seen me speak before, I've been in sleep medicine for over 25 years, but really talking about sleep in the context and the contrast with hyperarousal and how really I want you to leave this webinar today with the idea that insomnia is a transdiagnostic expression of hyperarousal, and one that is a modifiable risk factor and perpetuating factor of psychiatric disorders. I have some disclosure. I am the CEO and founder of Noctum. Some of the other conflicts are listed here. When I do speak about, I may end up having time to speak a little bit about some of the work that we're doing at Noctum. There will be this yellow exclamation point on the slide to remind you of the potential conflict of interest there, and I've added some independent references so you can verify independently that when I talk about our best practices in sleep medicine and in the context of insomnia, you have the references that I'm using, not just for the talk today, but for guiding the work that we do at Noctum. So I have 3 learning objectives today. They're listed here. I think it's first important to define what optimal sleep is before we start talking about not just how hyperarousal disrupts sleep, but how these sleep disruptions have direct impact on mental health, and most importantly, how we can target sleep issues not only to improve sleep qualities in patients, but also to improve daytime well-being and overall performance, readiness, and safety in different contexts. So what is optimal sleep? There are 4 different characteristics, components of optimal sleep, and they're all important. The first one is predictable. So sleep occurring at a predictable, regular time of day or night, depending on people's work schedule, but that you have a fundamental sense of when sleep is going to occur, when it's going to start, and when it's going to end, and when you're going to feel sleepy at the end of the day and alert at the beginning of the day or after an episode of sleep. So optimal sleep needs to be predictable. It also needs to be consolidated. It's not only that you know when sleep is going to happen and end, but that this period of sleep is very consolidated, not fragmented, meaning that people fall asleep and they stay asleep throughout the night. And that's really a requirement for the third component of restorative sleep, meaning that after an episode of sleep that is not only consolidated and predictable, people wake up feeling refreshed and ready for the day. And then the last one is really having a sufficient opportunity for sleep. And it's really, when we talk about sleep, we think of quality over quantity. The second thing I want you to leave this webinar with is the um, uh, going over the myth that we need 8 hours of sleep to have optimal sleep. The duration of sleep is quite variable from one person to another, and most adults feel refreshed and ready for the day with around 7 hours of sleep. Now, the National Sleep Foundation recommends between 7 and 9 hours for adults, but typically 9 hours is on the longer side, and so is 8 hours. So as long as sleep is predictable, consolidated, and restorative, the duration that fosters these three other characteristics is really what we're aiming for when we look at sleep reconsolidation. So, and we know that sleep is important, not just because it's a very enjoyable activity, but because it's involved in the homeostasis, or the balance and the regulation of a number of different brain and body functions. And I've listed some of them on this slide here. Some of them that you'll recognize are key symptoms in people with different psychiatric challenges. Of course, and we've all had the experience of having a bad night or a few bad nights of sleep and experiencing what the consequences are the next day, with being more anxious or maybe being more reactive, feeling more depressed, being slower in thinking and reacting, making poorer decisions, increasing the risk or the level of risk that we're taking. And then there are a number, as I said, of body functions that are listed here that are significantly disrupted in the context of chronic sleep disturbances. And those are some of these pictures really represent some of the consequences or long-term consequences of chronic sleep problems. We know that there's a very strong relationship between obesity and weight management and poor sleep. Same thing with performance, with training, with performance on tests. Much higher prevalence of car accidents with people who have disrupted sleep, not only sleep apnea, or who are fatigued, different risk for injuries, and significant relationship really linking sleep disturbances with an increased risk for psychiatric disorders. And I'll talk about that more in a little bit. People leaving their job, their occupations earlier when they suffer from poor sleep, and early mortality. So those are not small consequences. So even on the individual level, we know how the lack of sleep impacts us, but on the chronic version of sleep disturbances, they can be significant impact, not just for the person, but their family and their environment. So the main disruptor of sleep after poor sleep habits is really hyperarousal. And I've looked at different dictionaries, physiological manuals, and textbooks to find a good definition of hyperarousal. And actually, it turns out that the dictionaries have the ones that are the simplest, but also the more encompassing definition, and they're listed here. So when we think of arousal, we know how it feels. We've experienced hyperarousal, but it's hard to define and a little bit circular too in the definition. But generally, we're thinking of an increased state of responsiveness that may be to an external cue or an external stimulus, or some internal states to which we react to, that is marked by both physiological heart signs, heart racing, sweaty palms, or psychological symptoms of anxiety, which is where I think it becomes a bit redundant, but hyper alertness, hyper vigilance, and some of the other physiological manifestation. And this increased responsiveness results in, on the short term, in the feeling of anxiety, feeling fatigued, or just reduced tolerance to any kind of internal or external stimulation, including pain. Now, so the bottom line is that hyperarousal is some kind of hyper responsiveness to either an internal or external stimuli, but invariably, or in very few exceptions, it will lead to the disruption of sleep. And the most common disruption of sleep is insomnia. Actually, insomnia is the most prevalent sleep disorders in the entire world, not just in the US or Canada. And that's the point that I made early on, that I would like you all to think about insomnia as a transdiagnostic expression of hyperarousal. So we think of insomnia as a sleep disorders, but it is true that it is a sleep disorder or a sleep syndromes that oftentimes characterize all types of psychiatric challenges, but it's also true for medical conditions, either acute or chronic. What you see on this slide is the definition of insomnia. So it's the problem falling or staying asleep, and that's really operationalized as taking longer than 30 minutes to fall asleep or being awake at night for longer than 30 minutes. It's something that happens at least 3 times a week for at least 3 months. That's when we think of chronic insomnia. But it's not just a sleep that is disrupted. Insomnia is characterized by having the daytime consequences related to the sleep disruption. And these daytime consequences, I've mentioned a few already. They're listed here, and I'm sure we could increase that list. But for the diagnosis of insomnia, it's not just the disruption of sleep, but it's also having daytime consequences that result from that sleep disruption. Now, insomnia is not sleep deprivation or sleep restriction. So I want to make it clear that when people have a sufficient opportunity to sleep and they cannot sleep, then we think of insomnia. But if people, as many of us do, shorten the amount of sleep they dedicate, the amount of time they dedicate to sleep, then we're thinking we may experience the same daytime consequences that are listed here. But now we're not talking about insomnia. We're talking about sleep restriction, sleep deprivation, or insufficient sleep more generally. So it's an important distinction to keep in mind that people need to dedicate a sufficient amount of sleep to meet the criteria for insomnia. So if I put it all together, I've talked about insomnia, hyperarousal, psychiatric disorders, and I think we can think of hyperarousal as one of the sources that can, or the precipitating factor and potentially perpetuating factor for both insomnia and psychiatric disorders. In general, in the field of mental health, we still think of insomnia as a result or the consequence or the symptom or being secondary to psychiatric disorders. But back in 2010, the National Health Institutes or Institutes of Health, NIH, did a pretty deep dive in the literature that existed on insomnia at the time. And what they concluded is that actually there is effectively a bidirectional relationship between insomnia and psychiatric disorder, but that in the majority of cases, insomnia precedes the onset of psychiatric disorders. And that's why I'm saying that this says insomnia can be not just, it's not a specific psychiatric disorders, but it's often a precursor and a precipitating factor. And if you think about it, it makes sense too. If you don't sleep well for an extended period of time, these daytime consequences become chronic. And of course, that the severity of these consequences or of these symptoms become clinically significant. And that's really the side of the relationship that I want to focus on for the rest of my presentation today. The other point I want to make, and I alluded to this, is that instead of thinking of insomnia as secondary, which the data does not support, it's more accurate to think of insomnia as a comorbid condition to either a psychiatric or a medical condition. And when we put insomnia on the same level or on a comorbidity scales with other conditions, then we have an actionable therapeutic target. thinking of insomnia as secondary effectively does not serve our patients well. And what it'll do is, and we know it does, is it perpetuates the under-treatment of insomnia. And we know that untreated insomnia actually is a factor that contributes to poor recovery from different stress conditions or psychiatric disorders, or accelerate relapse from psychiatric conditions that were previously treated. So my third point today is reminding you to think of insomnia as a comorbid condition rather than as secondary symptoms. And there's neurobiological evidence, in addition to epidemiological studies and longitudinal studies, that support this idea. What you see here, and I promise I won't go deep into the neurobiology of insomnia here, but Eric Knopfsinger here at the University of Pittsburgh in the early 2000s developed a method that allows us to look at brain metabolism or brain activity while people are sleeping using PET imaging. And what he did here, what you see, is comparing people with primary insomnia, so uncomplicated insomnia in the absence of any medical or psychiatric comorbidity, and look at what does their brain look like when they're sleeping in non-REM sleep, or part of the deep sleep that is more restorative, that is one of the aspects of restorative sleep. And what you see here is that the areas that are involved in maintaining alertness or arousal during the day remain much more active during sleep in people with insomnia compared to good sleepers. So all these hot spots that you see in orange and yellow there are part of this hype or this arousing or arousal system that remains much more active during sleep, when these should be completely attenuated, as it is the case in good sleepers. The same kind of pattern we can see also during sleep in people who have psychiatric comorbidities. What I'm showing you here is a study that we did over 10 years ago at the University of Pittsburgh, looking at combat exposed veterans with and without post-traumatic stress disorder, and also looked during non-REM sleep at how comparing their brain activity using the same methods. And what you see here is that in combat exposed veterans with PTSD, it's not only the arousal systems that stays online while they're sleeping, but the other regions that you see here are the regions that are involved in modulating arousal, threat detection, and avoidance of threats. And this is the case even when we study people in the lab, there's no difference on polysomnography or the EEG measures that we take, but they all report significant sleep problems. So even in the absence of our traditional objective sleep measures, we can see that people who have insomnia, either uncomplicated or comorbid insomnia, show much more activation in brain regions that should be clearly attenuated during sleep. And we also know that from epidemiological studies, and this is a prospective study, looking at a group of soldiers before deployment and looking if any of the sleep measures that were taken predicted resilience to combat deployment or stress exposure. And what you see here, the bottom line is that sure, combat exposure increases the risk of developing PTSD. Those are the adjusted odds ratio. And both anxiety did not significantly increase the risk for developing a new onset depression. But when you look at having a short sleep duration before deployment, having insomnia before deployment, or having both, all increased the risk of developing either PTSD, anxiety, or depression post deployment. So there's this notion, and that's one of many studies now that I've shown, that prior to exposure to stressful events, certainly combat, is a risk factor that increases the likelihood of developing a psychiatric disorder. And this is true even when people don't have a prior history of psychiatric illnesses. And this is a separate study also conducted in veterans looking at predictors or just sleep quality, generally speaking, prior to deployment, and whether or not people had a history of psychiatric diagnosis or not. And what you see there is that when people complained that their sleep was of poor quality prior to deployment, they were at much higher risk of developing PTSD, major depression, a substance use disorder, or any psychiatric disorders, regardless of whether or not they had a history of psychiatric difficulty before their deployment. Again, this is just one example of many studies that have been conducted, but when we put them all together, and I'll spare you the full review of the literature, when we put them all together, we come up with this model where clearly the data is indicating that either the existence of poor sleep or sleep disturbances prior to exposure to stress, or early or the insomnia developing after stress exposure are both actually a risk factor for poor psychiatric outcomes, so compromised resilience to stress. And these kinds of relationships have been found to be true for all the disorders and conditions listed here. Now, what that also means is that we have a target then to kind of change that path, alter the path, and promote resilience, accelerate recovery through sleep reconsolidation or sleep recovery. Sleep is also, and that's you can see on the slide here, is that not only is insomnia a transdiagnostic expression of hyperarousal that is a characteristic comorbid condition to psychiatric disorders, but it is also a primary transdiagnostic target that is modifiable to enhance resilience and psychiatric outcomes. For the sake of time, I don't have time to go into all of these studies, but I'll show you a meta-analysis. Now, let me go back here for a second. As I said, the good news is that insomnia is a treatable condition. We have excellent treatments for insomnia that are effective both in the context of uncomplicated insomnia and insomnia comorbid with any psychiatric conditions, really. The first-line therapy for insomnia is CBTI, or cognitive behavioral therapy for insomnia. It's been well established, and it really refers to a group of evidence-based techniques that are designed to enhance the consolidation, the predictability, the sufficiency, and the restorative aspect of sleep by targeting daytime and nighttime behaviors and cognitions that we know contribute to perpetuating insomnia. It's very behavioral, more behavioral intervention, if you want, than cognitive. But it's a multi-component. CBTI is a multi-component intervention or protocol. The most, across different meta-analysis, the most effective techniques for insomnia are stimulus control and sleep restriction, which is a misnomer. It's really wake restriction. Stimulus control is designed to reinforce the associations between sleep and sleepiness and one's bed and bedroom. So you're not supposed to do anything but sleep in your bed. Everything else should be done outside of bed. Sleep and sex is what we usually say. To really reinforce the association between sleep, sleepiness in the bed or the bedroom, and alertness or awake with other environments. Humans are creatures of habit, and reinforcing these associations has actually a direct impact on the mechanisms that regulate sleep and arousal across a 24-hour cycle. The other strategy called, well, I hear it's sleep restriction, is the traditional name, but it's a misnomer. What we do is with the wake restriction is we allow people to be in bed only for the amount of time that they actually sleep currently, plus 30 minutes to give them the time to fall asleep and to go back to sleep relatively quickly throughout the night. So what we do with this technique is really calculating how much sleep a person currently gets. So if it's 5 hours, allow them 5 hours plus 30 minutes in bed, time the onset and offset of sleep, depending on the person, but typically to their preferred rise time, and then schedule their bedtime accordingly. Those two oftentimes are done in combination and are the most effective insomnia treatments. Relaxation techniques can also be helpful in cognitive restructuring, although in most studies that we have with CBTI that have dismantled the different components, the cognitive restructuring component is also, as we do outside of CBTI, accompanied with behavioral experiments to test or to challenge these dysfunctional beliefs about sleep. So that's a general idea for CBTI. This is the first-line therapy for insomnia that is recommended by the American Academy of Sleep Medicine, the Canadian Sleep Society, the European Sleep Society, the American College of Physicians, WHO, and other professional associations. So there's good agreement that the first-line treatment for insomnia is CBTI. And I want to make a point here to remind you all that sleep hygiene is not a treatment of insomnia. Sleep hygiene is a list of do's and don'ts to promote healthy sleep practices. And they're important, and we should all practice these healthy habits. However, in the context of insomnia, there's also plenty of evidence that healthy sleep habits are not sufficient to treat insomnia. And I know that oftentimes people will say, yeah, no, we do treat insomnia. We offer sleep hygiene, or we have a sleep class, or we provide some kind of sleep education, which is great and a good foundation, but again, insufficient when it comes to the treatment of insomnia. So how does it work in the context of hyper or arousal related psychiatric disorder? And what you see here is a recent meta-analysis. It's not the only one. They're pretty consistent, even when you look at ones that are published a decade or more ago, is that when we look at the effectiveness of CBTI to treat insomnia comorbid to other psychiatric conditions that are listed here, you see effect sizes or improvements in the insomnia, the severity of insomnia, that are in the moderate to large or very large range, meaning that even when you focus on insomnia and treated insomnia, and people have any of these comorbidities, you can expect to have clinically significant improvements in sleep, clinically significant reductions in insomnia severity. And these effect sizes and the range, or the confidence intervals that you see there, are actually pretty competitive, if not a little bit higher than what you find when you look at the first-line treatments for depression, PTSD, alcohol dependencies. So treating insomnia can yield the same kind of improvements in sleep as you see when you focus on the non-sleep or on the whole condition, if you want, if there's a sleep component. So then, of course, the question you want to know is like, well, yes, it improves sleep, but does that improve daytime functioning? And the answer is yes. When you focus on sleep, on these sleep meta-analysis across different studies that look specifically at the impact of CBTI on sleep, and what are the consequences on daytime symptom severities, the other symptoms that people are experiencing. Again, you can see moderate to large or very large effect sizes that are also competitive with the first-line treatment recommended for these conditions. So I'm biased. I'm a sleep person. So definitely, I've been encouraging people for decades now to target sleep first as a therapeutic focus in the context of treating other psychiatric conditions, because not only are the improvements significant and relatively fast, the course of CBTI will take anywhere between 4 to 8 weeks in most programs, but you also have clinically significant improvements in the person's well-being while they're awake, while we're doing therapy, and that might actually create the context for not only better adherence, but a larger impact for these treatments. That's a hypothesis. There's some studies that have looked at it. Now, sorry, before I go to that. So we have CBTI. There are different resources. If you're interested in training or learning more about it, please you can look at you will have the slide deck. So the references that I cited is where you'll find some of this information. Now, as I mentioned, typically when we deliver CBTI, the traditional protocols are face-to-face. Now it's either in person or telehealth. Will last anywhere between 4 to 8 weeks. The abbreviated version of CBTI, or a brief behavioral treatment of insomnia, is also effective. And it's typically delivered by someone who has extensive training in behavioral sleep medicine. Now, it's a highly, highly potent intervention. But in our field, in behavioral sleep medicine, one of the main challenges that we have is that there are very few trained CBTI experts around the entire world. There's actually a registry that, according to the last time I looked last week, there were fewer than 500 people in the entire world that specialize in cognitive behavioral therapy for insomnia. However, there's 1.5 billion people in the world who suffer from insomnia. So we've had looked at different strategy to see how do we enhance the scalability, the accessibility of CBTI. How do we provide solutions to healthcare providers across, not just in the sleep clinics, but across all domains who aren't seeing and serving patients with insomnia? How do we provide the tools for them? How do we provide the resources so that their patients can be adequately treated for insomnia, given the clinically significant improvements that we know we can see? And right now, this is, if you want, what you see here is where we are currently with our different attempts to scale accessibility to CBTI. So there's traditional CBTI. I mentioned there's an abbreviated version, BBTI, that is essentially the same, just a little bit shorter. It's also efficient, but that requires live interaction, as I said, either in person in the office, or now with telehealth being more accessible and more common. That kind of serve people with insomnia in a one-size-fits-all type of approach, that the protocols are the same, tailored to each individuals, but the protocols don't change that much, whether we see someone who has very severe sleep problem versus somebody who comes with maybe less complicated insomnia. For people who have milder types of insomnia that are relatively uncomplicated, there are some self-help apps, books. There are books that are excellent. Some written by fellow Canadians. Colin Carney has an excellent self-help book out there for insomnia. And there's a number of apps, some that are you have to pay for, some of them that the patients can access freely or at no cost, to help not only monitor their sleep, but do some of these mild recommendations to try to manage insomnia. And then, as you all know, there's a proliferation of all kinds of sleep sensors and trackers, but typically those are really not for the treatment of insomnia, but for optimizing sleep in people who already have baseline good sleep. Now, I think one of the issues that we've had, as I said, in behavioral sleep medicine is that there are too few providers, a lot of patients, and our traditional protocols are not necessarily something that fits well within the context of busy clinical practices, if they're not exclusively focused on behavioral sleep medicine. So I'm going to move in the section where I do have a conflict here, is that we've been spending quite a bit of work, and I started that when I was at the University of Pittsburgh, to try to find how do we increase the number of options that we have. Right now, we have human-only or tech-only solutions to scale not only providers' capability to offer the first-line treatment for insomnia, but also to accelerate how long patients wait before they get access to this first-line treatment, which is on average, depending on the studies, anywhere between 14 and 25 years. So I've been looking at how do we increase the number of options that are tailored to the patient needs, that allows provider specialists to really focus on more complicated cases, but provides the other providers the tools that they need to be able to not only maintain the continuity of care of their patients, but to address insomnia in their own clinical practice. And I've already mentioned the limited scalability, so that we could keep CBTI or BBTI for the patients who need that level of care. Keep the self-help apps for people who need this, who have the discipline and have a level of insomnia that is manageable, that is self-manageable. But how can we add a step here in this idea of stepped care for insomnia that could be a combination of human and technology? And that's what we've done with COAST at Noctum. It's COAST stands for Clinician Operated Assistive Sleep Technology. And it's really a tech-enabled strategy that allows us to manage people with mild, moderate, and even severe sleep problems who can be managed using technology remotely, asynchronously, so that they can get access to the treatment faster, that the providers get the information that they need to be able to personalize the treatments, and allow patients who need the level of care, the highest level of care, where they need to be seen face to face to access the treatment much, much faster. This is what COAST looks like. It's not a self-help app. It's actually really a tool that is designed for providers. It's tech-enabled CBTI if you want, but it's really designed, the whole platform is designed around the providers and around their workflows. Now, we understand that not everyone's an expert in behavioral sleep medicine. As I said, there are very few that are registered around the world. But we have our practice parameters in behavioral sleep medicine are very clear on what to do and how to personalize, how to implement some of these techniques that we know are effective for treating insomnia, and how to monitor patients as well. So what we've done is built into the platform these best practices, the evidence-based practices that we have to guide the clinician through how do you adapt a given, the best treatment recommendations for a given patient. So if we want, we can standardize the personalization of treatment that works, but also provide the clinician with the support that they need and know that they're recommending treatments and personalizing insomnia treatments within the boundaries of our best practices. And of course, we have to engage the patient. So there's a patient app that allows patients to report and share not only sleep diaries, but different assessments, but to communicate in real time, just-in-time information that is relevant for their sleep care with their providers. So it's really designed to be an asynchronous type of delivery for monitoring and managing patients. Here in the US, the term is remote therapeutic monitoring that allows to do this. And we've done a number of studies, and that's obviously such a commercial product, and we're really data science is in our DNA. So we monitor very closely that the kind of improvements that we see in insomnia in patients who are treated with COAST with their providers do just as well as people who receive the first line CBTI treatment. And what you see here is the meta-analysis I referred to before, really looking at patients who have insomnia and comorbid conditions, because that's really the bulk of the people who are treated by their physicians or clinicians using COAST. And both, actually, traditional CBTI and CBTI delivered through COAST are more effective. They're the most common insomnia treatment, which remains medications, hypnotics, even though we know there are risks associated with hypnotics. So I'm going to wrap up, take time for questions, but a few take-home messages is to bring it to the front of your mind that sleep is really a pillar of health, that insomnia, that hyperarousal, that insomnia becomes a transdiagnostic expression of both acute and chronic hyperarousal. And that if we change and shift our ways of thinking about insomnia from being secondary to actually being a coexisting condition, a comorbid condition, then it becomes a primary therapeutic target where we can see improvements very fast. and not necessarily to treat the comorbid conditions that right along with insomnia, but to attenuate those daytime symptoms and allow patients to continue therapy or work that they're doing in the treatments for those comorbid conditions. We have effective CBTI is one of the most effective treatment. It is the first line recommended treatment for insomnia. It is true for uncomplicated as well as comorbid insomnia. And as I said, it's great that people sleep better, but they also reap the benefit of feeling better during the day and seeing attenuation in symptoms of comorbidities. And then there are different resources, as I mentioned, I'll be happy to share with them. And I hope that, and we've been working towards kind of enhancing awareness that we have effective solutions for different groups of patients, the self-help apps and the traditional face-to-face therapy, but that's still not enough to meet the demands of patients who come with comorbid insomnia. So there are different solutions. Ours is really looking at tech-enabled solutions for a broad range of healthcare providers. But we need all the solutions that are available, and we need new solutions, again, to be able to meet the demands of our patients. So with that, I will conclude. I'll take care for take time for your questions. You have my contact information there. Don't hesitate to reach out. Thank you very much.
Amazing, amazing, amazing presentation. We should definitely throw an applause into the chat. Dr. Germain, you did such an amazing job. That was a really, really informative webinar. We have lots of questions for you.
Thank you.
Which is not at all surprising. For folks who put questions in the Q&A, I will do my best to get to all of them, but it's really, really exciting. So without further ado, let's jump right in. So our first question is, what is the relationship between new mothers lacking sleep and developing postpartum depression?
There are a few studies that do show that they're at increased risk. It gets kind of blurry because all new parents, mothers and fathers as well, will have curtailed sleep because of the newborn. So it's really whether or not people have the capabilities or the ability to sleep when they have an opportunity for sleep, or if they have insomnia prior to or during pregnancy that develops, that perpetuates over time. Generally speaking, insomnia or poor sleep is one of the most robust predictor of depression. And it's also true for postpartum mothers.
Amazing. Thanks for that, Dr. Germain. Next, we have a question from Monica. What would be the best CBTI resource for therapists to use with clients?
So there are many. Your best friend, behavioral sleep medicine, is a sleep diary. You need to know on a prospective basis when people go to bed, how long it takes to fall asleep, how many times they wake up, how long they're awake, what time they're awake. So to be able to see how far are they from optimal sleep that is regular, predictable, restorative, and sufficient. There are a number of great books for clinicians that are available. I mentioned Colleen Carney in Ontario actually has both a patient workbook and a clinician workbook that are extremely helpful. There are a number of resources online. If you type CBTI, you'll find several of them. And recently, there's a group at the University of Texas in San Antonio that has created an online training program for clinicians in CBTI. It's self-guided. It has all the references, all the materials that you need to do sleep assessments. I'd be happy to send me an email and I can share the link to this. I believe it's called webcbti.org. And there's one for the treatment of nightmares too. So for those of you who work with people who are trauma exposed or have a history of trauma that also have nightmares, they have the same kind of training for imagery rehearsal therapy or the first line treatments for insomnia for nightmares.
It's really, really interesting. Thank you for that. Our next question comes from Simran. First, a big thank you from Simran for the awesome presentation.
Thank you.
Their question Their question is around oversleeping. What is considered oversleeping? And could oversleeping in adults, let's say ages 18 to 30, lead to health-related risks and issues?
Yes. So typically we consider long sleepers anyone who sleeps 9 hours and more, or that's the cutoff that is used in prospective longitudinal and epi studies looking at the relationship between sleep duration and health outcomes. Typically sleeping, now there are people, let me just say first, there are people who are naturally long sleepers. That's fine. That's good. There are people who are naturally short sleepers. That's also fine. But typically when people, it's not necessarily the sleep duration, is if you sleep 9 hours and you wake up rested, refreshed, and you have all the energy you need for the day, you're good. If despite sleeping not 9 hours, there's sleepiness, fatigue, and episodes of sleep throughout the day that are not refreshing, like you take a nap and it doesn't help, then it's when we start thinking of disorders that are hypersomnia. So basically, the alerting or the arousal system not being fully on when people are awake. 18 to 30 is actually a period of vulnerability where people will start expressing symptoms or reporting symptoms of narcolepsy, for example. So if that's the case, that people sleep for 9 hours and they have functional problems during the day, they fall asleep, they can function at school or at work, it's a good time to go to a sleep clinic and get a full sleep and daytime evaluation. The other sleep problem that is the second most common sleep problem is sleep apnea, when people either stop breathing or their breathing is limited at night. We think of the prototypical patients of sleep apnea as an older gentleman. That's not true, actually. A lot of the breathing, if you want, the airflow when we're sleeping is heavily determined by the anatomy of the upper airway. That runs in family. So if somebody between the ages of 18 or 30, or really at any ages, has a family history of sleep apnea, sleeps very long at night, can nap anywhere, anytime for extended periods of time and never feel refreshed, I would say it's also time to consider same thing. Go to a sleep clinic and they'll be able to determine what kind of sleep problems is most likely to be occurring. They're not necessarily mutually exclusive, and how to best treat them.
Really, really interesting. Thank you for that. We have our next question from Danielle. Danielle, well, they're asking if the slide deck would include resources around CBTI with children, but I think it'd be good to highlight, like, are there any CBTI resources for therapists and for children?
Yes, there are. The difference with CBTI in children, I would say before the age of 12, 11, will engage the parents to implement certain bedtime routines and morning routines. There are some good resources. Jody Mindell is a thought leader, an expert in the area, really, that I typically refer to. Danny Lewin, back when he was at the NIH, also had a whole protocol for children and parents for children who had insomnia. So there are good resources. The principles of the treatments are the same. It's really the resources that are utilized, the parents really that are engaged in the treatment for their children.
Amazing. Thank you for that. We have a question from another Danielle, and they're asking if you can speak to the connection between insomnia and hyperarousal and ADHD, and if the treatment options you suggested are still effective there as well.
They are still effective there as well, with the additional consideration that the timing of, so I'm thinking of ADHD and insomnia in the context of there's ADHD and insomnia with and without ADHD treatment or medication, right? So oftentimes what you will observe and what you're familiar with, and that's not my area of expertise, is that either the child or the adolescent or even the adults, once at the end of the day, when medication wears off, if they're on medication, they'll be extremely tired, they can fall asleep. Or if they don't, they still have problems falling asleep, staying asleep, wake up earlier than they want to. The same treatments are applicable, except that in the context of medication, the timing of medication, the dose and the type might actually have an impact in contributing to insomnia. The best thing to do then is to go back to the physician, the prescriber, bring up these concerns so that they can determine, is it a question of splitting the dose or the timing of the dose or a different agent that may still have the benefits of the medication during the day without having the consequences or the potential side effects of disrupting sleep at night.
Super, super interesting. Thank you for that. We have a few more questions. Are you good to still keep going?
Yeah, I'm good to go.
We got the rapid fire questions today. So it's awesome. It's awesome. So we have a question from Andre, which is, how significant an influence do you think caffeine intake is for folks who have full daytime schedules but still struggle to sleep at night?
Oh, yes. So caffeine, can't do without it. So the amount of caffeine and the timing of caffeine intake is important. I mentioned during my presentation that sleep hygiene is not a treatment for insomnia. So a lot of people with insomnia will cut caffeine, or they'll be very, very mindful to not have any kind of caffeine intake before or after noon, for example. So have it in the morning, but not in the afternoon. The trick with caffeine is that there's quite a bit of individual variation of how quickly we can metabolize caffeine. There's this idea that it takes 4 hours to get out of your system. It can take up to 12 hours for some people. And the sensitivity to caffeine is also different. So we all know someone, there might be some of you that say, well, I can drink coffee right before I go to bed and I can fall asleep right, which is fine because caffeine actually takes like 30, 45 minutes to actually kick in, or 20 to 30 minutes to have its full effect and kick in. So if you go to bed in that 20 minutes, you'll be fine. There's actually a term for that. It's called a nappuccino, but I'll set that aside. So the importance with caffeine is to be mindful of the amount and the timing. People who work night shifts, for example, will use caffeine to help them stay alert, but they also have to be mindful of when is their shift over, when are they going to be able to go to bed in the morning, so that the peak of caffeine effect is going to be passed and allow them to fall asleep. But yes, cutting caffeine is one of the first thing, or not necessarily cutting going to zero, but the timing of caffeine and the amount is one thing that we look at very closely in the treatment of insomnia to get that potential factor out of the way early on.
I love that term, nappuccino. I'm gonna keep that one if that's okay.
So yes. So I'll just say a quick word on that. So the idea of nappuccino is that because there's a window between the time you ingest caffeine, you take a cup of coffee, and it actually kicks in, there's a 20 to 30 minute window, which also happens to be a good duration for a power nap. So there's this idea that if you drink caffeine, go for a nap, and wake up, you'll have both the enhanced effect of the caffeine intake and the restorative aspect of having the tactical or strategic short power nap, and that it can help with performance. And there's small studies that I've looked at it, but nappuccino is a catchy term, so it's gone around.
Awesome.
I myself have tried many times, but I get too excited, I can't fall asleep. So
I think we have time for one more question, but just want to say a couple quick things before we get to that last question. First, everybody give another round of applause to Dr. Germain. This was a very, very fantastic presentation, and nappuccino is now my new favorite thing. Before we get to that last question as well, just so everyone's aware, because I know we do have some fantastic clinicians in the room today, we are hiring nurses and clinicians in the Rockies and in BC. So if anybody is interested in exploring that, feel free to reach out to hiring@ehncanada.com. And bonus points. These bonus points are important if you tell them that Jonathan sent you. So we'll go with that. Actually, we have one really great question here, which is, what is your view on using cannabis for sleeping? The big one.
And I wish we had the science and the data to answer the question, but we don't, unfortunately. Cannabis use is way ahead of what we know, well, medicine in general, certainly in sleep medicine. There's very few studies that have been done. Oftentimes it's studies of people who report being like frequent or habitual cannabis user, comparing the people with and without cannabis use on subjective and objective sleep measures. And the literature is really all over the place. So just generally, not even in the context of insomnia, but and even the few studies that have been done to try to use cannabis or a cannabinoid to treat insomnia are first very small, and some are positive, some are negative. So unfortunately, we don't have the answer to that question yet.
Awesome. Thank you for sharing that. And one last question here from Kaylee, and then again, thank you so much, which is what are your thoughts on using EMDR for sleep insomnia?
So I'm a big fan of EMDR. I'll say that from the get-go. The typically sleep or insomnia and different from nightmares. So I'm really focusing on insomnia here. Insomnia tends to not be the focus of an EMDR session or groups of sessions in EMDR. So I don't know how specifically for insomnia. I do know that when EMDR is used for nightmares or for other trauma-related memories, that as people get better, their sleep can also get better or improve a little bit. I said I'm a biased person, not because of the company, but because I'm a sleep person through and through. So for years, I've recommended that people start with sleep or treatment of insomnia and nightmares so that people can recuperate overnight. And then when they get to more intense or demanding emotional memories or therapeutic work that they do during the day, they do so on a more rested brain that allow them maybe to go a little bit deeper or to tolerate higher levels of distress. It's a great question. I wish the EMDR trials and studies had more to say about the sleep components, the insomnia components, because it may also have the same kind of magnitude of effect, but I don't believe that the answer is in the literature yet.
Awesome.
So this is a great study that you could do.
There we go. And actually, I did miss one question. Do we have time for one more?
Sure, I'm free.
And then we got all the questions. Completionist. Okay. And it's from Jane. And the question is, how do you use CBTI to work with untreated trauma? Do you wait for trauma treatment to start first?
Nope, CBTI first. And again, this is not because there's a ton of data. This is more my personal experience and biases too, where CBTI can be very effective to alleviate insomnia, even in the context of trauma, of PTSD. That it's oftentimes easier. I've always said, we start with sleep because improvements in sleep are felt and experienced very fast. Like within 2 to 3 weeks, people they'll feel sleepy, they fall asleep faster, they'll see benefits in their sleep very early. Not only having a better sleep consolidation is also helpful, and that's tons of study looking at this, that it's also helpful for memory consolidation or memory reconsolidation. So in the context of trauma work or PTSD, having the ability to sleep more in a more consolidated way may actually enhance the effect of PTSD treatments that are more trauma focused. I always said too that it's easier pitch to tell people that we're going to work on their sleep first, and then see some improvements very quickly, and then tackle more difficult emotional issues or trauma-related issues. And that's what we do generally in therapeutic work. In CBT, we have a hierarchy of issues that we work from not the most severe, not the mildest one necessarily, but not the most severe and escalate. And I think sleep is one where people are motivated, they're interested. It's not emotionally demanding, not that it's easy to do, but they see the benefits very quickly. And I think that gives a good foundation to tackle more demanding therapeutic work.
Amazing, amazing, amazing. Dr. Germain, thank you again so much for doing this webinar with us today. Even I learned quite a bit from this as somebody who has never even started to explore this stuff. So I can only imagine for the people who are really involved in this field, how much they got out of it. So again, thank you so much. Thank you to everyone for coming out, and we'll see you at the next webinar. Have a fantastic day, everyone. Take care.
Thank you very much. It was a pleasure.